So this is my first time in Charleston, and it's a beautiful city and a beautiful venue you guys have, and thank you to the committee for inviting me down to speak today. So I'm not going to bog us down with the data slides early because the three of you have done an absolutely wonderful job of going through that. Realistically, you've all given my talk already. I've got some pretty slides to basically go through the points that have already been made. I think the best part about being in this conference is it's truly a multidisciplinary conference, that we bring out the ideas of working as a team and working with multiple specialties. I think everybody knows that March is DVT Awareness Month. We're actually holding competitions within our flagship hospital throughout the whole month of March on the vascular ward. So my task today was to talk about the key components of what a complex venous center is, how to build a practice, and what do you need. So this is what vein surgeons do, right? This is it. This is, we live in a beach community. You guys are in a beach community. These are what my patients look like, unfortunately. This is a 37-year-old woman who had phlegmasia. She ended up needing fasciotomies after a complete open IVC embolectomy. So there's myths about what it takes to build these programs. I'm one of the youngest people probably speaking this week, and the myth is that I can't build a program from the ground up. And when you pull up the Yellow Pages or Google or whatever we use now and say, what's out there, it's full of vein doctors. The reality is there's a lot more to venous disease than cosmetics, and I haven't really heard a lot of cosmetic talks today, so that's sort of been already debunked. The venous disease is still largely ignored by the medical community. Dr. Cherry said he had a patient with a complete venous occlusion by tumor, and the patient at one of the best hospitals in the world was told probably nothing to do, and he had to find a different surgeon who'd come back to the vascular surgeon and say, what can we do? And realistically, your community is looking for a venous champion. So if you build it, they will come. So my partners think that I do May-Thurner, I do iliac vein occlusive disease. They like to think we do nutcracker syndrome, which we probably don't even think exists. And there's some large vessel occlusive disease that we take care of and some thrombotic stuff, and we use a lot of angiovac. And if you were to poll my partners, they would tell you that's my day and that's my practice. This is really what you do. So to build a comprehensive program, you kind of start at the bottom and work your way up. You have to have a superficial venous disease practice because that's where a lot of these patients come from. You have to deal with VTE. You need to deal with post-thrombotic syndrome. You need to deal with the non-thrombotic occlusive disease, the non-superficial vein reflux disease, and you need to get into congenital abnormalities because you need to have an understanding of the pathophysiology to take care of these diseases. And you probably can't do it alone. So when I started to say, where can I find these patients? How can I find these? I trained in New York, and one of the senior guys there who had a fairly bustling vein practice told me, I know where all the vein patients are for this process, and I'm not going to tell you. And to this date, he has still not told me, and I will meet with him again in New York this year and say, well, I think I found where they are, and I'll show him. Mind your own practice first. Many times your partners have seen patients and didn't have the tools in the toolbox to do what they needed to do. And if you have an interest in this, talk to your partners. They will send you patients. I see patients that have for 7, 8, 9 years been told there's probably not much to do. We just operated on a retired Korean general in the US Army for a total IVC occlusion. He's been occluded since 2003. Talk to your local competition. It helps that I work at the Regional Referral Center, the dreaded outside hospital that always sends disasters. The local competition tends to be really well-trained, qualified people who just either A, not interested, B, it's too much work, too hard, or it just wasn't part of their core vascular practice. These are all excuses that I've heard in the last 3 years. I started an IVC filter retrieval program for our system, and the dreaded venous ulcer, within our office, we started taking care of all of our venous ulcers ourselves. So our early challenges were figuring out what our referral base was going to be, how are we going to manage our patients that had other associated problems like wounds and anticoagulations, can we track these patients, can we follow these patients, and do we have room within the practice to scale it and let it grow? So the easiest thing for a young surgeon who spends 75 hours a week in one hospital is to work within the hospital. So we partnered with the administration to prevent VTE events. For those of you not familiar with the PSI events, PSI 12 is directly related to decreasing hospital VTE events and will be bundled to reimbursement. Typically, PSI 12 is only post-surgical. The hospital was kind enough to let us take our VTE initiative system-wide for all patients and not just post-op patients. So once they had a financial goal from the government, we could come with a clinical goal that was better for patient care and say, let's not just try to get the extra 1% from Medicare, let's try to actually help everybody. And I'll tell you, when your patient care goals align with your system's financial goals of reducing costs and increasing reimbursement, it's really easy to ask for something and get what you want. The next thing we did was we built an inpatient VTE consult team. I have 6 fellows, I have 2 residents always on service, and 3 PAs, and we're swamped busy. So asking them to see VTE consults is a giant pain in the butt. That being said, we've increased manpower, we've come up with ways to streamline their care, and we don't see every clot that comes through, but I'll certainly tell you we see all the big ones, we see all the massive PEs and the submassive PEs, and we can tailor appropriate care. It's really important to offer a comprehensive service. If you open the doors as a VTE service and all you do is write in the chart, no indication for surgery, sign off, you're not getting called again. The critical care docs will tell you they know better than you on their stuff. The cardiologists will tell you they know better than you do on their stuff. It's a lot easier to offer a comprehensive service and help with the VTE management. There's really nobody in the hospital interested in running that service. Market directly to the doctors that are going to see complex large vein occlusive disease. So if you're not a vascular surgeon and you're an interventional radiologist, interventional cardiologist, talk to the other specialties that might see these. If they have an interest, work together. If they don't have an interest, offer to take the patients and share with them what you've done and how you've done it. The more you share, the more cases you show, the more patients you're going to get. Talk to your critical care specialists and talk to pulmonary medicine. There is a gold mine worth of patients there. I will tell you that most of my patients now actually come from surgical services. The non-anticoagulated trauma patient or the non-anticoagulated neurosurgical patient typically get large vein occlusive disease, and working in conjunction with them to determine initiation of anticoagulation, SCDs, TEDs, as monotonous and as daily as that is, those consults become rather easy, and even if I only see 1 or 2 patients a month from them, those numbers add up over time. Our outpatient referral base comes from standalone vein clinics. Most can't, won't, or don't offer services outside of sclerotherapy and ablation. Education is the key to referrals. Every large hem-onc group has a couple guys that don't do much cancer. They like the hematology stuff. They follow these patients. They maintain their anticoagulation. And they've got a dozen patients with post-thrombotic syndrome that likely have a central venous occlusion. They're out there in your community looking for somebody to help them. Wound care centers are certainly a must. All venous ulcers should have a deep venous assessment. Centera Healthcare has 13 hospitals. We have 4 wound care centers. We've recently partnered with a national player called Restorix Health for wound care. That's going live now. I'm not sure what I think of that. So what I did was I internalized the venous wounds. We have our own vein center that runs 5 days a week, and we took all of our own venous ulcers and we have healed 85% of them in 3 months. And there's new patients coming in all the time. We maintain between 25 and 40 venous ulcers a week in our practice. I won't spend a lot of time on this slide, but make sure you have an anticoagulation plan. Make sure it's reasonable. The chest guidelines are terribly, terribly liberal. I will tell you, for deep venous reconstruction, for deep venous anticoagulation, much like Dr. Cherry said, aggressive anticoagulation is a must. I can't tell you that anyone in my practice with an iliac vein clot gets a limited 3 months of anticoagulation. At the very least, it's 6 months with reassessment, but much more likely a year plus reassessment. Find the expert hematologists in your region and work with them. If there's a local standard of care, it's the local standard of care for a reason. If it's not working, feel free to change it, but work with the guys who've been in the community forever, because there's a reason why your community does what they do. And I'll tell you to at least consider the novel anticoagulants. The number of Coumadin failures we see is probably not drug related, but certainly in my community, it's dose related. One of the nice things about the VQI program, and hopefully we'll have our Virginia's data ready for April, Dr. Cherry, I'm working on this now. Utilize patient navigators. There is money in your system to track these patients. In 2014, we had a paltry 25% filter retrieval rate system-wide. That's not just vascular surgeons. We decided to take our dialysis nurse patient navigator and give her the task of tracking IVC filters. In 2015, we removed just over half. However, we identified and touched 86% of those patients and made a long-term plan. We have a goal in 16 of a 75 filter removal rate in patients that are considered non-forever implants. Imaging, 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 imaging. For those of you who weren't trained in vascular ultrasound or in non-invasive vascular imaging, go back to the basics. I know, Dr. Veeraswamy, you said that you don't like central duplex. I put this picture in because I took this picture with the tech in the patient's bedside just this week. And yes, he's skinnier than the average patient in Georgia, but I too live in the Biscuit Belt, so my patients are large. This is a great quality image. I mean, yeah, we're only 4 centimeters deep, but there's an iliac vein in a recent neurosurgical trauma patient with an iliac vein stent and about a 50% luminal reduction on the anterior wall with thrombus. It's a great picture. We do IVC duplexes on everybody. APG is a forgotten art. Typically, our APG machine was put in a storage locker. The storage locker was sold. I don't think it made a TV show, and it's gone. It turns out our lower extremity arterial Dopplers have a venous mode. Find a way to get a physiologic assessment of your patients, because typically with these chronic PTS players, understanding what their symptoms are from is the key to treatment. Again, imaging support is really important. Phasing of contrast is key. We just recently ordered CTA, abdomen, pelvis, rule out IVC thrombosis, and in big comments wrote, please do venogram. It was missed by the tech. So we met with administration. They now have a new CTV order. It took a 6-minute meeting and an oops, we're sorry, we scanned the wrong patient at the wrong phase, and the problem's taken care of. MRVs are great too. There's certainly better reasons to do one over the other depending on your patient. Fixed imaging, IVUS. I don't think anybody's really talked about IVUS. IVUS is really one of the biggest key supports to doing a deep venous reconstruction endovascularly. We use IVUS in every single one of these cases. It helps you size, it helps you see residual thrombus you can't see. It's really a wonderful boon to our practice. This is controversial. Go to meetings, talk to administrators, partner with administrators. It's a really hard thing as a surgeon or interventional radiologist to go to these meetings and not put the spoon through your eyeball. Go to the meetings. They are not a waste of time. There are some check-the-box meetings. Send somebody else. Find the junior guy. That used to be me for a long time. But go to the meetings, and go to the meetings where you can make a tangible difference. Be on the new products committee. I think these are pretty much all the toys talked about today. On the bottom right is a cleaner wire and a Teratola. Teratola is rather old. I use it in almost all my angiovac cases. They're great little toys. It's easy to get what you want from administration. When you prove you're sending the patients out sooner, there's better outcomes and there's cost savings. Get physician support, get some buy-in. Make it a team-based approach. It's better to work with rather than against your competitive specialists. And don't disparage the competition. My hospital, the biggest referral center in Hampton Roads, is 455 beds. It is a tiny little level 1 trauma center, which means all the other small hospitals around me aren't all that small, and there are plenty of certified radiologists, cardiologists, vascular surgeons doing some of this. Teach them when to send you patients. Teach them when to put it up a notch. My best referrals are from the other guys after they've tried or before they've tried. Offer all the services. That includes open venous reconstructions. It includes cosmetics. Find somebody in your group, in your competition that will work with you, so you really don't need to refer folks out. And finally, stay active with research. This is our current research list just in the venous world. We work with IDE trials. We do new indication trials. We're on the National Registry, and we look at our own data. And with that, thank you guys very much for the invitation.